Hope this finds you well. I'm going to help you through the biliary tree pathology, and today is the last Friday of this year, and I'm gonna be having more videos almost every week, and hope you keep you posted. And today in the biliary tree pathology, this is the main objectives. We're going to look at the anatomy, the pathology, the diagnosis, and the treatment. So just to start, I'm gonna take you through what the biliary tree is. As you can see, there's something here that looks like a tree, and this involves the ductiles from the left and the right liver, that is the hepatic ducts, and they come over to form the left and the right hepatic ducts, and this when they join together with the there should be a right and left hepatic ducts. We join together to form the hepatic duct, and the hepatic duct will join with the cystic duct, and the cystic duct comes from the gallbladder, and they join to form the common bile duct. The common bile duct, as it moves down behind the first part of the duodenum, it joins with the pancreatic duct, and at this point it's called the ambula of Vater, and they have a smooth muscle called the sphincter of Oddi. So basically this is the biliary tree. As we said, from the liver you have the hepatic ducts, they join together with the cystic duct, they form the common bile duct, and at the end the pancreatic duct is not really part of these discussions we're going to have today, but it joins again to form the ambula Vater with this muscle, smooth muscle, called the sphincter of Oddi, and this is where everything is released. So from the liver we have bilirubin, that's what we'll concentrate on, coming from the liver. From the cystic duct we have the bile salts, and from the pancreas we have the pancreatic enzymes, all of them coming together and coming to the second part of the duodenum. Basically this is where we're going to concentrate today, and I hope you will enjoy this presentation today. So to start, I'm going to give you a summary of what is choledocholithiasis. So from lithiasis means there's a stone forming, and mostly it's because of stasis or sludging. And this is chole. Basically, if you see chole, think about the gallbladder. That is the gallbladder right there. And this is another review of the anatomy, that we have the gallbladder. It has the cystic duct, the common hepatic ducts, and this is the left. The left will be there, and the right hepatic ducts, and all these come up together to form a common bile duct. The common bile duct will join the pancreatic duct, and all this will empty at the second part of the duodenum. So when we say choledocholithiasis, and I will try to show you that choledocholithiasis is stones. Basically these are stones which are gonna form in the gallbladder, and these stones some few individuals may be having these stones, and these stones basically in the gallbladder, they can cause some pain, and that's right upper quadrant pain. And if you have right upper quadrant pain associated with food, and that is fatty food, and this pain usually radiates to the right shoulder. Yeah, if it radiates to the right shoulder and takes mostly about half an hour, and it's gone. So it's colicky pain that is very intermittent, and typical person who gets this kind of pain is 40-year-old. That's F, that's why I wrote there 4 F's. And if you can remember, this is a fertile female, and we said it's a female, and female 40 and fertile with and most likely is associated with fat. So this this will give you a kind of scenario of if a clinical vignette is presented to you, that 40-year old or 42 years old presents to you, female with this history and is fat, has a BMI, let's say, of 30, a BMI of that, and presents with this right upper quadrant pain, and it's radiating to the shoulder, and it's related to going to McDonald's where you expect to have fatty meal, and he has this pain that comes in 30 minutes and it's gone. So your differential should be choledocholithiasis, and usually it doesn't present with peritoneal irritation. There's no irritation and there's no signs of inflammation, so that means there's no fever, no leukocytosis. So what do? This patient comes to you, you want to do an right upper quadrant ultrasound, and I showed you the right upper quadrant. If you divide the abdomen like this, with this being the umbilicus, this is the four quadrants, and there's another way of dividing it, but this is what we're talking about, the right upper quadrant. So you do a right upper quadrant ultrasound. This is not an emergency, therefore you're gonna go ahead and do an elective laparoscopic cholecystectomy. And again, I want to emphasize on the types of stones you expect. There are two major categories of stones, and these ones will be cholesterol stone and pigmented stones. For such kind of scenario, you expect the cholesterol stones to be the main stones that you're gonna get. The pigmented stones are usually associated with diseases like spherocytosis, maybe sickle cell disease, and these are what you expect in pigmented stones. We're going to move ahead and talk about acute cholecystitis. So acute cholecystitis basically is inflammation of the gallbladder, and this will be caused by a stone right here. If you have a stone at the cystic duct, this is a stone, and the stone is going to cause inflammation of the gallbladder, and this is where you will expect to have inflammation and thickening of the gallbladder. So basically this patient, because there is inflammation, and you know inflammation is associated with fever, leukocytosis, peritoneal inflammation of the right upper quadrant. So the right upper quadrant, you have somebody presenting with fever and leukocytosis with right upper quadrant pain. So what do you think about this? Some form of inflammation, and this is because of a stone at the cystic duct. So what do you do? How do you find out which clinical examination can you do? One of the things you can do is to check for Murphy sign. So Murphy sign, basically you're telling the patient to inhale, and when this patient inhales, the diaphragm will flatten, and if it flattens, it's gonna push the liver down, and if it pushes the liver down, and this is where the gallbladder will press against the hand, and if you palpate at the right upper quadrant, that means the pain will be there. You have pain at the right upper quadrant at this point of inhalation. So a clinical vignette will try and explain and try to give you all these features and showing you that the patient has fever and leukocytosis. Therefore, there is peritoneal inflammation and Murphy sign is positive. So that's one way. Before even you do other things, you will know that this patient has acute cholecystitis. So if you go ahead and do LFTs, because you have done your CBC, that's differential count, and now you do your LFTs, which is the liver function test, you expect it to be normal at this point. Guess what? Your stone is right there. If it's right there, you don't expect the common hepatic duct to be affected. Therefore, anything coming from here, which is we expect, is bilirubin. So bilirubin, the liver is detoxifying and it's bringing down bilirubin through the common bile duct. So your LFTs basically will be normal, and that's where it comes down all the way down without being affected by a stone that is at the cystic duct. So if you do your ultrasound, what do you expect? If you do an ultrasound, you expect to see gallstones. So basically still you can see gallstones and maybe more at the cyst, because that's where they are causing the obstructions. You can see gallstones also at this gallbladder, but majorly they have to be at the cystic duct. That's why they are causing the obstruction. So the other thing you can see is a thick walled cystic duct. This is thickness because of constant inflammation. There, you expect it to be thick, and if you see some fluid, which we call pericholecystic fluid. If you see that fluid, that's pathognomic. And if I say pathognomic, like, you need to highly think about acute cholecystitis. Then what about if this ultrasound is not diagnostic or it's equivocal? I mean, you can't make a decision whether this is acute cholecystitis or not. What do? You go ahead and do a HIDA scan. A HIDA scan basically is a scan you do. Let's say in simple language, you give the patient some chemical, and this chemical is supposed to come all the way and go all the way to the gallbladder. But because of the obstruction, this gallbladder will not be seen. So when you do a HIDA scan and you don't see the gallbladder, that means it's positive for acute cholecystitis. So if you have made that diagnosis, you want to go ahead and stop anything the patient is eating and have the patient kneel per oral. You have IV fluids, start antibiotics. Be careful which antibiotics you're giving, especially if you don't want to give, for example, you want to avoid it, but if that is the only thing you have, you can give it. But remember, things like ceftriaxone, they cause biliary sludging. So sometimes you want to consider that when you have such kind of patients. But remember, this is not definitive. You want to do some definitive therapy, and this is where you want to do a laparoscopic cholecystectomy. Remember, you can also do open surgery. It's never done in most places, but if that is you don't have laparoscopic surgery, you can go ahead and do surgery and get the bladder out, because that's the problem we're having. At the same time, if the patient is very sick, a very sick patient, let's say the patient has cardiac disease, is an old man who has so many things going on, you don't want to go and do this surgery. What can you do? Do you know what you can do for that patient? You're going to go ahead and do percutaneous cholecystectomy. And hopefully through this you will have helped the patient and stabilize the patient. So next we're going to talk about another condition called choledocholithiasis. So choledocholithiasis basically means there's involvement now not only of the gallbladder, it's also involving the common bile duct. So the second CHO, for me, I take it to be CBD, that's common bile duct. And lithiasis, as we said earlier, that means there's a stone. And we said if it's cystitis, that means it's inflammation. But this is just the stone. So you go ahead and now realize that this is the common bile duct, this is the cystic duct, and this is the common hepatic duct. So basically now here you're having a stone right there. And if you have a stone right there, you're blocking everything up. So what do you expect? The common bile duct is obstructed. What do you expect there? There's dilation of the common bile duct. It will be dilated. If you see dilation of the common bile duct, forget about cholecystitis, forget about cholelithiasis, forget about those. Think about choledocholithiasis. That's what you want to think about at this point. So you have choledolithiasis at this point, and you have the dilatation of hepatic duct, because they cannot dilate unless there's obstruction distal to the hepatic ducts. So these are the patients who don't have any inflammation, and therefore they'll not have no fever, no leukocytosis. But remember one thing, if you do your LFTs, what do you expect? It's obvious. If you have a problem obstruction, the hepatic duct is obstructed. Remember, the bilirubins are coming like this, bilirubin. Okay, so if you have bilirubin being obstructed right there, you want to go ahead and think that it's something in the common bile duct. Therefore, the direct bilirubin, this is conjugated, is going to be elevated. So anytime I talk about direct, I say direct surgical, or I say direct surgery, because that reminds me that direct bilirubin, whenever it's elevated, that means you want to do a surgical procedure to help out this. And what do? Whatever you do at this point is you want to do an ERCP. Remember, ERCP is endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography. This is gonna be therapeutic and diagnostic. Remember, you can do other things. Like MRCP, and MRCP is magnetic, and all the other things remain the same. So magnetic is only diagnostic. So if you have a clinical vignette talking about, and you think it's choledocholithiasis with increased bilirubins, direct bilirubins, no fever, no leukocytosis, the only difference is LFTs that has a problem, you want to go ahead and do ERCP, not MRCP, because you can do both. You can diagnose and you can do therapeutics. You can also do an ultrasound at this point. It can show you all this, but it's not going to help you to treat the patient. This is diagnostic, at the same time it's therapeutic. Okay, so at this point we're going to discuss about cholangitis, ascending cholangitis. And basically, ascending cholangitis is where we have a mixture of choledocholithiasis and signs of infection. Now we have signs of infection coming in. And this can be leukocytosis, part of it, coming in. We have fevers coming in. And these are patients who will look very sick, actually. Sickness is not like they look very sick, and they might be old patients. Yeah. And if you want to characterize that patient, the patient has choledocholithiasis, as we said right there. So choledocholithiasis plus signs of infection, or let me say sepsis. So there are basic things you want to think about if this patient has ascending cholangitis, and it's summarized with Charcot's triad. So what is Charcot's triad? So Charcot's triad is when you have jaundice, and we have explained that jaundice will be there because of increased bilirubin, and this time we're talking about direct. Okay, direct bilirubins, and we say this is coming from their direct bilirubin is conjugated. We're talking of conjugated. Conjugated means it has gone through the liver and it's now coming to go down out of the body to the GIT, the gastrointestinal tract. So you have jaundice, that's direct bilirubin. You have fever. Patient presents with fever, as I said, sign of infection. At the same time, this patient presents with right upper quadrant pain. That's very important. You have the right upper quadrant pain with fever and jaundice. So for you to quantify that you have Raynaud's pentad, it's a continuation of 1, 2, and 3. That's jaundice, fever, and right upper quadrant pain with altered mental status, and you have low blood pressure. So why do you have low blood pressure? That means you have sepsis and you're going to shock. Okay, and as I said, typical patients, they are very sick patients, sometimes old patients. And if you do a right upper quadrant, and I want to show you how you can diagnose this again. Yeah, it's all about your clinic, your history, your physical examination. You find somebody who's jaundiced, who has fever, who has right upper quadrant pain, and you go ahead and realize that he might be having all this, including Raynaud's pentad, which includes altered mental status and low blood pressure, and this will come from your physical exam. Other labs that you can do, you may realize that this patient has elevated alkaline phosphatase. And also, now what you can do in the imaging, you want to do a right upper quadrant ultrasound, and that can help you to locate the stone. And also with the clinical findings, you can tie all these together to ascending cholangitis. Sometimes you will realize that the common bile duct will be dilated, but not always. So in some few cases, you may realize that the common bile duct, if you go and study and look at ascending cholangitis, sometimes you may not have a dilated common bile duct. So a dilated common bile duct, think about choledolithiasis with cholangitis if you have the other features of inflammation. So what do? You do an emergency ERCP, endoscopic retrograde cholangiopancreatography. Again, it helps you also in diagnosis, it helps you in treatment. The other alternative is percutaneous therapy, and this is a true emergency. You really have to be very fast and do it in time. So thank you for watching this video, and I hope I get your feedback, and let me know what you think and what you can improve, you want me to improve on, or what topic you want me to discuss about. I'll give you my few references. I used Step 2 CK, General Surgery Kaplan book, Up to Date, Biliary Pathology, and PubMed in some few topics here and there. And this is my few books that I have right there. And I'm also, as part of my studies is all these books. I also study to know. I have a book here by John and Stacy, and it's Unveiling the Mystery of Women's Soul. They say it's captivating, so hopefully I'll enjoy this as part of the studies. Thank you so much, and may God bless you, and see you in a week's time or so.